This article reviews sarcopenia, a condition characterized by low muscle strength, low muscle quality, and low physical performance. This peer-reviewed article is read to you using an automated voice, so some of the words and phrases may not be as you would usually expect to hear them. The full version of this article, with citation, references, and illustrations, can be found at nursingtimes.net under the musculoskeletal and orthopedics category. It comes with a multiple-choice self-assessment which, when completed, contributes towards your continuing professional development and revalidation requirements. Abstract. Sarcopenia is the gradual loss of skeletal muscle mass and strength, and is associated with age-related deterioration. There are multiple diagnostic tests, which have variations in muscle mass cutoff points. This article explains the different types of sarcopenia, why it develops, how it affects patients, and the importance of diagnosis. The author is Linda Nazarko, specialist frailty nurse at Sutton Health and Care, Epsom and St Helier University Hospitals NHS Trust. Introduction. In 1989, Erwin Rosenberg coined the term sarcopenia to describe the loss of muscle mass. The word is derived from the Greek sarko, flesh or muscle, and penia, loss. He later stressed the need for research to determine whether sarcopenia is an age-related loss of muscle mass and function, a disease, or a typical part of the aging process. The European Working Group on Sarcopenia in Older People published a definition of sarcopenia in 2010. This was revised in 2018 by the European Working Group on Sarcopenia in Older People too, which listed 3 criteria to identify possible sarcopenia: low muscle strength, low muscle quantity or quality, low physical performance. Low muscle strength is the key characteristic of sarcopenia. The presence of all 3 features indicates severe sarcopenia. Sarcopenia is a syndrome characterized by progressive and generalized loss of skeletal muscle mass and strength. It is associated with physical disability, poor quality of life, and increased risk of death. The NHS spends an estimated $2.5 billion per year managing the consequences of sarcopenia. It is difficult to determine the prevalence of sarcopenia because there is no single diagnostic test. The condition is assessed differently worldwide due to inconsistencies in the way the following factors are accounted for: diagnostic classifications, cutoff points, variations in muscle mass due to ethnicity and sex. Even when the same criteria are used, if different tools are used to measure them, they can give different results. In a literature review of 109 articles, Mayhew et al. 2019 identified that 8 definitions of sarcopenia were used. For this reason, the article's estimates of the prevalence of sarcopenia in community-dwelling older people varied from 10% to 40%. Additionally, a study by Ramirez et al. 2022 identified that using the European Working Group on Sarcopenia in Older People 2's guidelines from 2018 led to an underestimation of the prevalence of sarcopenia compared with rates when using the European Working Group on Sarcopenia in Older People's 2010 guidelines. Sarcopenia is more common in older people, and a study by Yazar and Yazar 2019 identified its prevalence among adults aged more than 80 years as 37%. Using Yazar and Yazar's 2019 results and population data from the Office for National Statistics, we can conservatively estimate that more than 5 million people in the UK have sarcopenia. However, this gives no indication of the severity of the condition. Types and causes of sarcopenia. Primary sarcopenia is related to aging, which affects muscle function and strength. Aerobic capacity, a measure of the ability of the heart and lungs to supply oxygen to the muscles, decreases by around 40% between the ages of 25 and 80 years. Adults lose up to 8% of muscle strength per decade after the age of 30 years, and from the age of 65, this falls even more rapidly. One reason for this is that testosterone, an anabolic steroid that helps to build and maintain muscle mass, falls by around 1 to 2% a year in men from the age of 50 years onwards. The accelerated decline of muscle mass, strength, and physical performance is sarcopenia. According to the European Working Group on Sarcopenia in Older People 2's guidelines, sarcopenia is considered secondary when there are causes other than or in addition to Aging. There are many causes of sarcopenia. These are age-related muscle loss, disease, inflammatory conditions, organ failure, cancer, chronic obstructive pulmonary disease, inactivity, bed rest, hospital admission, sedentary lifestyle, malnutrition, undernourishment or malabsorption, anorexia, and sarcopenic obesity. Around 30% of older people admitted to hospitals decline functionally. This can have long-lasting effects, including sarcopenia. One study of older people found that 6 months after discharge, 24% could still not walk a quarter of a mile, and 45% were still unable to drive. Sarcopenia can also occur because of poor nutrition. This can be due to lack of access to food, limited ability to cook or eat, anorexia, malabsorption. Suboptimal nutrition accelerates age-related loss of muscle mass and strength. Although sarcopenia is associated with weight loss, some adults with sarcopenia may be obese. Age-related endocrine changes are believed to be of particular importance in the development of sarcopenia. There is reduced secretion of growth hormone, insulin-like growth factor 1, testosterone, estradiol, vitamin D, thyroid hormones, and dehydroepiandrosterone. This leads to a reduction in muscle mass and decreased function. There is also decreased insulin sensitivity, which, combined with reduced hormone levels, affects the growth and repair of muscles. Conversely, levels of cortisol and angiotensin II increase with age. This can accelerate the rate of age-induced muscle wasting. Adipose tissue secretes molecules called adipokines. Adipokines are cytokines, small proteins that regulate inflammation, metabolism, immunity, and other physiological processes. Cytokines, such as interleukin, tumor necrosis factor, and C-reactive protein, are associated with reduced muscle function. Cytokines are thought to induce sarcopenia by activating the ubiquitin proteasome pathway, a process of cellular repair, which decreases insulin-like growth factor production, inducing insulin resistance. Acute and chronic sarcopenia. Sarcopenia that has lasted for less than 6 months is defined as acute. It is typically associated with an acute illness or injury. Sarcopenia that has lasted for 6 months or longer is defined as chronic. This is usually related to chronic and progressive conditions, such as chronic obstructive pulmonary disease, and increases the risk of mortality. The aim of categorizing sarcopenia as acute or chronic is to encourage the regular monitoring of patients. This is to facilitate early intervention to treat sarcopenia or delay its progression. Diagnosing sarcopenia. Sarcopenia is a disease that has been recognized only fairly recently. Patients who have it may be seen on an orthopedic ward, on a medical ward, on an older person's ward, by a GP, in a community service such as a falls clinic, as part of a specialist nurse's caseload. This means that clinicians may not be fully aware of sarcopenia or how it is diagnosed. The pathway recommended by the European Working Group on Sarcopenia in Older People too is that clinicians find cases, assess, confirm diagnosis, and determine severity. Sarcopenia is overlooked and undertreated in clinical practice. Further testing for sarcopenia is recommended when someone reports its signs or symptoms, such as falling, feeling weak, having a slow walking speed, having difficulty rising from a chair, experiencing weight loss, experiencing muscle wasting. One screening tool is the Strength Assistance with Walking, Rising from a Chair, Climbing Stairs and Falls, SARC-F questionnaire. This asks the individual to rate their ability to perform each of the 5 components on a scale of 0 to 2. A total score of greater than or equal to 4 is predictive of sarcopenia and poor outcome. The SARC-F questionnaire is not suitable for everyone, and alternative screening tests may be needed if literacy or cognition is a problem. As an example, the ISHI screening tool estimates the probability of sarcopenia by creating a score based on a patient's age, grip strength, and calf circumference. If sarcopenia is suspected or the SARC-F questionnaire suggests a patient has sarcopenia, the patient's muscle strength should be assessed. There are 2 components to this. Grip assessment, the sit-to-stand test. Grip strength is assessed using a handheld dynamometer. The result is interpreted using norms based on gender and age. The sit-to-stand test is carried out using a chair that has no arms and a seat height of 43 centimeters. The chair, with rubber tips on the legs, is placed against a wall to prevent it from moving. The patient sits in the middle of the chair with their back straight. Their feet must be on the floor, approximately shoulder width apart and slightly behind the knees. One foot should be slightly in front of the other to help maintain balance. Their arms are crossed at the elbows and held against their chest. The patient watches a demonstration and practices a few times. They are then instructed to complete as many full stands as possible within 30 seconds, fully sitting between each one. The person conducting the test silently counts the number of correctly completed stands. If the patient is more than halfway up at the end of the 30 seconds, this counts as a full stand. Their score is the total number of stands within 30 seconds, although if they need to use their arms to stand, they are scored 0. Scores typically range between 0 for those who are unable to complete the test and 20 for fitter individuals. Diagnosis can be confirmed with a dual-energy X-ray absorptiometry, DEXA scan, CT scan, MRI, or bioelectrical impedance analysis, BIA. DEXA is the procedure of choice for routine clinical assessment. However, parameters vary according to age, gender, and ethnicity, and are not yet well established. The method of determining muscle strength should be based on individual factors, including disability, mobility, and how acceptable a certain method is to the patient. DEXA is widely available and can determine muscle quantity non-invasively. Muscle mass is related to body size, and there are ways to take account of this. However, further work is needed to develop a consensus on methods of adjustment and use with a range of ethnicities, as current sarcopenia guidance is based on European populations. BIA can be used to estimate muscle mass. BIA equipment does not measure muscle mass directly, but instead estimates it based on whole body electrical conductivity. BIA is inexpensive, and the equipment necessary is easy to use and portable. Measurements used relate to older Europeans. Further work is required for other populations who may have differing levels of muscle mass. Calf circumference can predict performance and survival in older people, and may be used as a proxy measure of sarcopenia in certain circumstances. Dietary assessment is also essential because poor nutrition can cause and exacerbate sarcopenia. The National Institute for Health and Care Excellence requires care providers to screen for the risk of malnutrition using a validated screening tool, such as the Malnutrition Universal Screening Tool. Typically, height, weight, and body mass index are checked, and a screening test is carried out. If there are concerns about weight loss, or if the individual is not eating, a detailed assessment should be carried out. Patients who are poorly nourished may need to be assessed and treated by a dietitian. People with sarcopenia need an optimal intake of protein and vitamin D, which may necessitate nutritional supplements. If they have swallowing difficulties, an assessment by a speech and language therapist is required. They will also need to have a medication review, as they may be unable to swallow certain prescribed medicines, and some can impair swallowing. Impact of sarcopenia. Healthy aging means remaining physically and mentally well. For example, being active, independent, and able to socialize. Sarcopenia can have an enormous effect on quality of life. This can be temporary or permanent. There are many impacts of sarcopenia. Physically, it causes reduced stamina, impaired mobility, and an increased risk of falls and fractures. It can also lead to depression and impaired cognition. People with sarcopenia may struggle with activities of daily living and need help with personal care. They may enter a downward spiral, become more dependent, and then need long-term care. Xu et al. 2021 identified that, especially when accompanied by impaired mobility, sarcopenia is associated with increased one-year mortality. As sarcopenia can have a devastating effect on a person's quality of life and increase their risk of death, clinicians must be aware of the condition and not assume that low muscle strength and impaired ability and mobility are simply a part of aging. In hospital and primary care settings, clinicians need to consider sarcopenia when a person has a chronic progressive condition, a history of falls, accelerated physical decline, and/or impaired nutrition. Our knowledge of sarcopenia is growing, and we are increasingly aware that interventions can prevent and manage the condition, thereby reducing its impact. People are living longer, but those longer lives are often marred by activity restriction, resulting from a long-lasting physical or mental health condition. The average woman in the UK experiences 22 years of disability, and the average man 16 years. Therefore, the NHS needs to change from being primarily a disease management system. Its primary function needs to be promoting health and well-being, and disease management needs to be its secondary purpose. Conclusion. Sarcopenia, the gradual loss of skeletal muscle mass and strength, is associated with age-related deterioration. There is no single diagnostic test for it, and clinicians need to understand the different types of sarcopenia, as well as its causes and impacts. Diagnosis is essential to improve patients' quality of life and reduce their risk of mortality. Key points. Sarcopenia is characterized by low muscle strength and quality and low physical performance. Primary sarcopenia is related to aging, whereas secondary sarcopenia occurs with another condition. Different diagnostic tools can provide differing results. Dietary assessment is essential because poor nutrition can both cause and exacerbate sarcopenia. Sarcopenia has physical, mental, and cognitive impacts, including increased mortality. Now you've listened to the article, test your knowledge with the Nursing Times self-assessment. If you score 80% or more, you will receive a personalized certificate that you can download and store in your Nursing Times portfolio as CPD or revalidation evidence. The full version of this article, with references and illustrations, can be found at nursingtimes.net under the category Musculoskeletal and Orthopedics, along with our AI search facility, Ask Nursing Times, which allows you to explore the subject further. Thank you for listening.